me to briefly introduce today's speaker. Dr. Ashten Duncan is a core faculty member at Medicos del Centro Family Medicine Residency in Española, New Mexico, and a 2024 graduate of the UNM Santa Fe Family Medicine Residency Program. Dr. Duncan received his medical degree from the OUTU School of Community Medicine in 2021 and earned his Master of Public Health degree from OUHSC Hudson College of Public Health and his Bachelor of Science degree in microbiology from the University of Oklahoma. In 2023, he received the American Academy of Family Physicians Award for Excellence in Graduate Medical Education. And originally from Moore, Oklahoma, Dr. Duncan was drawn to New Mexico for the opportunity to serve marginalized populations effectively, recognizing that different cultures require different and non-conventional approaches to their care. His medical interests include native and tribal health, outpatient and behavioral medicine, lifestyle and integrative medicine, public health, and applied research in primary care. With that said, Dr. Duncan, thank you very much for joining us today, and the floor is yours.
Thanks so much. Hi there, everyone. Yeah, it's a pleasure to be here today to present on the topic that's really near and dear to my heart. Today, we're going to be talking about some of the intersections between medicine and public health, and I do want to take us through those intersections from a theory standpoint. So we'll be going through three major theoretical frameworks that are often used in public health work that really do overlap with a lot of the care we provide to our patients each and every day. And so I'm very, very excited to talk about all of this. All right. All right. And hopefully everyone can see that there. So the topic for our presentation today, we're going to be going through the applications of those major public health frameworks I was talking about to primary care practice in New Mexico. Now, as part of this presentation, we are going to have a Slido option. And so right up there, you'll see a QR code on the screen you can scan to get logged into the Slido. You can also type in the name of the website there and use that code 2018-650 to join the room. So there are going to be some audience engagement questions later in the presentation, as well as a general Q&A session. To keep everything moving along pretty nicely, especially since we have a pretty big group here in Santa Fe, I am going to ask that everyone who does have a question put that in the Slido rather than taking those one by one by mouth, just so that way we can keep everything in order here. So I'll leave that up for a few more seconds. So if you still need to join, do that now. All right. Well, to go ahead and get started with the obligatory disclosure slide. So no financial or organizational conflicts of interest to disclose. This is purely for educational purposes, for the purposes of our didactic series, and then also for the education of our residents and other healthcare professionals who are joining us. All right, so for today's presentation, we're going to have 4 learning objectives. We're going to go through the first 3 pretty quickly, but spending a little bit more time on that third one, and then spending much more time about the application piece of it, as you saw in the title of the presentation. So by the end of this, I do expect for everyone to be able to define public health and list its 10 essential services, to describe the various components of public health infrastructure here in New Mexico, to identify several common theoretical frameworks in public health, and specifically the 3 we're going to be covering today are going to be the social ecological model, health belief model, and social cognitive theory. And we're going to apply the aforementioned frameworks to common primary care challenges here in New Mexico. So let's jump in with the first one. So what the heck is public health? Now, I realize for a lot of us, it can be a little bit challenging to define public health because of its very collaborative and very multidisciplinary nature. But there is a definition, I think, that is really helpful to really hang your hat on, and that some of the residents actually over here in Santa Fe have heard before. So the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private, communities, and individuals. So it is, a field that's really based in health promotion and prevention, but there are some interventional pieces that are involved in it that just don't exactly mirror what we consider to be interventions in the biomedical model. Now, there are 5 core competencies of public health that most people who go through to study public health learn. So we have biostatistics, epidemiology, social and behavioral sciences, health policy and management, and environmental health sciences. But really the beauty of public health, and really where it's most effective, is actually in that cross section that you can see there in the middle. And Again, public health is concerned with prevention and intervention, but the big thing to consider is that all of this is happening at the population level as opposed to the individual level that we see in most medical care. And now this is both distinct from, but also complementary with the biomedical model, which to another slide that several residents here probably recognize is that slide to really distinguish the two. Now we won't go point by point on this, but just to highlight a few of those key differences that allow for physicians and other healthcare professionals to interface with public health. The primary focus of a lot of our work in medicine is around the individual. You know, there's one-on-one healthcare visits, that care in the hospital, all of this happening at the individual level. Public health really looking at populations and subsets of populations and really focusing on the public service ethic, which is a little bit contrasted with medicine that really kind of focuses more on the personal service ethic with, you know, with an emphasis on social responsibilities. Now, the other big thing to note here is the diagnosis and treatment dichotomy, contrasting that with the prevention health promotion aspect of public health. But again, a lot of these things do go together very well. And what I hope you can leave with after today's presentation is how these two can really come together, and you can really provide some very effective community programming as a result of it. Now, the other part of our learning objective for that first one was to talk about the 10 essential public health services. Now, I made sure that we got the updated one because the CDC recently updated the 10 essential services to really emphasize equity. Previously, this was really a focus on research and generativity around the field of public health and making sure that we were producing things that would later translate to action within communities. Now, just to highlight a few of this, though, I'll first point out along the outsides of the 10 essential services, the kind of three key domains of assessment, policy development, and assurance. All of this unified under the equity umbrella. A lot of what is going on in different areas of public health falls into one of these three domains. And most often when we talk about assessment, it's not enough to just identify problems or to just simply point stuff out, but to actually identify areas for intervention to really study it. In the biomedical model, a lot of physicians are trained under the quality improvement model of plan, do, study, act, which is not too dissimilar to what you're seeing here. Because again, this is actually intentionally designed to show you the cyclical nature of all of this work. We will get into a lot of the policy development side of it and how this works, the communication side of this, which is essential for forming these teams that are really necessary to carry out all of these services, and to really also on the assurance side to understand the importance of diversity in your workforce. So again, something you can look up and see on the CDC website, but I just wanted to have everybody familiarized with that here. All right, so let's get a little bit more concrete. Let's talk about the way that this actually plays out in New Mexico, because we do have a very specific structure to all of this. And I'm going to comment first on what it looks like across most parts of the United States. So this chart right here is really just to show that general public health organization. So for most parts of the United States, and this is kind of vis-a-vis the 10th Amendment, a lot of the policing power actually falls down to the states. So most of the administration of public health services falls under state governments. And so that's why you see here that we're actually organized under the governor. So this is actually usually a function of the executive branch. Most states have a pretty similar structure. Some do have a mixed model where there are private components to this, but a lot of them do fall into the public sector. So most states will have a state Department of Health, which is the same as New Mexico, and there will be either a cabinet secretary or some sort of state health officer that really serves in the leadership role in regards to the administration of the whole department. Now, there will be different divisions under that. And I don't want you to commit any of these to memory here because they're actually different from New Mexico. But basically just to understand that within kind of the larger scope of the State Department of Health, there are specific priorities that the department is tasked with carrying out. And those divisions are the ones that usually will oversee this. And a lot of the specific services that we think about, including things like vital statistics, fall under one of our divisions. So let's talk a little bit more in detail about New Mexico. So under the New Mexico Department of Health, as we talked about, this is an executive branch agency. Our cabinet secretary right now is Patrick Allen, and the secretary will report to the office of the governor. which will, involve any major changes within the department and major updates that would be important for the governor to know. Organization of various offices, which this is where it gets a little bit more nuanced, follows mostly the kind of the state, regional, local structure, depending on what the function of the office is. So a lot of the public health offices, which you may have noticed if you've been around the state for a little while, many of them are at the county and city level. So some of the biggest ones we actually see in our most populous county down in Bernalillo. But there also are regional officials who actually operate within the 4 major regions of the Northeast, Southeast, Southwest, and Northwest of New Mexico. And a lot of the administrative offices are set up with that focus in mind. A lot of the programming does fall at the community level and is either operated directly by or at least funded by the Department of Health. So those divisions I was talking about. So this is just a list of the way our specific department is set up and the way public health is mostly administered in the state. So there is a specific division for public health services, but I would argue that if this particular division actually has very specific objectives just under that umbrella, but a lot of the public health services we talked about really do translate across all the divisions that you see here. So everything from public health, epidemiology and response, scientific laboratory, developmental disabilities supports, health improvement, administrative services, facilities, and medical cannabis. So it is interesting because you'll also notice that some of these go from being pretty broad, such as the public health division, to those that are much more specific once we get down to special divisions like the medical cannabis one. Now, this is a direct screenshot from the website. What this contains is some of that specific programming. And so when we talk about the services and what's being provided, there is a quick and easy way to look at all of this on the state website. So I do encourage everyone to take a look at that later on, especially if there's any particular area that you have a personal interest in, or if you find yourself involved in work that puts you more in that area. Oftentimes, as physicians in particular, we do find ourselves, often working very closely with some of these divisions, whether it's from reporting infectious diseases or in working with special programs to get patients connected with services they may not otherwise have access to. So just keep this in mind for later. All right, so now we're going to get down to our third bullet point. Now that we have a little bit more of an understanding of the general setup for public health, what it looks like in the state, let's talk about these theories and really break them down to a point where we can use them in practical terms. All right, so before I introduce social ecological theory, I think it's always important to step back and actually talk about what the heck we're talking about. So all of this discussion that we have around the different levels of organization within society and the way and Brenner's work around ecological systems theory. So this came about mostly in the 70s and really took off in the late 70s under Dr. Bronfenbrenner's publications. So what his main argument was is that human development is shaped by complex interactions between individuals and their environments. Now, in his work, it wasn't just enough to really identify, and the environment is just the environment, but to rather break that down into different layers, all the way from a microsystem out to a macro system, which all relate back to how closely these different factors interact directly with the individual. So we won't go, we won't go through each and every point there, but you can kind of, see how, these factors really go from small to very large into even what he described as the Cronus system, or just the role of time and how that plays into the development across each system. But some of the things that might look familiar from the social ecological theories and the microsystem, we are talking about things like where we go to school, our places of worship, where we work, our families, and getting out to more complex systems that build up to the people we know and the people we interact with in those systems, to entire communities based in neighborhoods and even our online environments, because that's actually become increasingly more diffuse and more all-encompassing of our experiences as people living in the world nowadays. But really getting out to the macro system, we see things like culture, attitudes, values. So we're really getting into these large societal contexts, which brings us to this. So this is the model that I think most of us probably at least have seen before, if not know pretty well. A lot of this that we talked about within ecological systems theory relates directly to this, and in fact, directly made it to where we can have this today. So a lot of times when we're talking about the macro systemic factors, we're often talking about policy, especially here in the United States. But this can also be, the way policy influences culture, which we often see. But again, remembering that there is always a ripple effect going both directions here, but that the most direct interactions happen at these layers that are the closest to one another. So between the individual and other people, and between other people and the institutions they create, and then the communities they create. And so I want you I want to take a moment to to let you all know that this will be something we're going to come back to and really try to use in depth. So if you wanted to take a quick picture of this or just make a few notes about this, we're going to be going into a lot of depth. If you're very familiar with it, don't worry about it at all. Just remember these key points here. Because this is really important no matter which level you're working at. And firm understanding of this is really important for tackling a lot of our primary care challenges in the state. All right, so let's move on to our second model. So the health belief model may be a little less familiar, but some of you may actually recognize this one as well. This came about, I think in terms of trying to understand some of the failures and uptake of different services that had been occurring for many decades. But there were some specific concerns around, for example, like why some people wouldn't accept certain vaccines, and this was well before the pandemic that we were running into issues like these. And so there were several teams of researchers that came together to really, to hypothesize as to what was really driving specific types of health behaviors. So specifically, I'm going to point out this very end part of this, because when we talk about health belief model, the most important part is the health behavior. So it's whatever we're really trying to get people to do. There are some alternative models that are actually pretty closely related that actually aim to look at kind of the unhealthy behaviors, or the ones that we hope for people to avoid, things like smoking, not wearing their seatbelt while they're driving, not wearing helmets while operating motorcycles and bicycles. But for the sake of our discussion, let's focus on the behaviors that we really hope to see. Now, a lot of this actually probably makes intuitive sense that a lot of what drives behavior can come from a person's culture and a person's upbringing. So we look here really on the left-hand side to get some information about what this person is actually bringing into any interaction. So demographic variables, age, gender, ethnicity, SES, education, psychological characteristics initially play into more of kind of the priming behind this, and whether people really are going to lean into a particular behavior, whether it's a suggestion from a healthcare professional, say to take a certain medication, to pursue a certain type of preventive measure. So that's kind of, again, I think intuitively that makes sense. The rest of what's really going on, it comes down to this middle part here. So there are two main domains within the health belief model with two components to each. And the two main ones are really the assessment of the behavior, which is really how hard is it to do and how helpful is it going to be. So that's those perceived barriers and benefits respectively. And then the perceived threat, which is if I don't do this, what bad could come my way? And there are really the way that this was built out was really to consider two main things. So first is the perceived severity, which is really around if I don't do this, how bad would the outcome be? So by a raise of hands, actually here in the room in Santa Fe, how many of you all wear your seatbelt when you drive a car? So everyone, right? But why, right? Because the likelihood that you're actually going to be in a serious accident is admittedly actually pretty low. But it's because if something does happen, the severity of that could be fatal, right? So you do it because it's a simple measure to avoid a very catastrophic outcome, even if it is somewhat improbable. And that's the same calculation that many people will make, even on a smaller level, whether it's using, taking metformin for their diabetes, for taking a blood pressure medication. And so the other sides of it are the self-efficacy, because, there is a piece of this about how able people feel they are to make a certain change. And also the cues to action, which some of us have probably done, because we've probably all been in the room with somebody where a spouse is sitting there, a child is sitting there. This person has a motivation for making that change outside of themselves. And that is that cue to action. So again, if you wanted to snap a quick picture of this, take a quick note, we're going to come back to this one as well and use this again in more depth. Give a few seconds there. All right. So our last one, social cognitive theory, a little bit faster to explain, especially in the framework that or rather in the frameworks we've already talked about. So social cognitive theory was mostly the result of Albert Bandura's work, and really came, Bandura really posited that human behavior could be, what determines human behavior can really be boiled down to three main domains. So cognitive factors, which are really the individual level factors, behavioral factors, which is kind of more the social domain to all of this, and then the environmental factors. So a lot of this goes back, it probably looks pretty similar to what we talked about with the health belief model, that a lot of what people bring into a situation to determine whether or not they should actually change what they're doing really comes down to things like knowledge, expectations, attitudes, and all that cultural milieu that we talked about before. The behavioral factors, are really more, I would really argue, and the way I think about this from a positive psychology side is an externalization of affective, which is more the emotional side, and then cognitive factors. And so when we look at behavioral factors, these are the things that people can directly observe and the things that they see you doing. But they're also the things that you actually did and didn't just think about too. And environmental factors too, to imagine what it might be like to not be in a community where something is normalized, that, maybe something is either frowned upon, or that something is it's not what your brothers did or your sisters did or your parents did. And then the access piece, because when we get into our cases, I really want us to remember this most strongly here. So again, one more slide here, and this is the last one. If you all wanted to take a quick picture or just make a note of, this will be the last one we'll be using as we go through our cases today. Okay, so now we're going to get in with our final learning objective and really spend some time here. But before I turn it completely over to audience engagement, really get your thoughts on all of this, I'm going to walk you through a case that I worked on with the Department of Health last year. So, induced termination of pregnancy services in New Mexico. Most of us have a pretty firm understanding of this and probably a pretty vested interest in this topic because of the patients we've seen, our personal professional interest, whatever the case may be. So I'm going to briefly just give the overview. Many of you probably already are already very aware of a lot of the big policy changes that happened over the past few years. So let's start from the top. So Roe versus Wade decision. This was a landmark U.S. Supreme Court decision in 1973 that established that pregnant individuals have a constitutionally protected right to autopsy. And specifically, there were a lot of limitations placed on states' rights within that. So this was a lot of the arguments came down to a 10th Amendment argument around this. States had some latitude in deciding how much to restrict access, depending on their own personal abilities to provide services, and also the ideological underpinnings of the state. So these were things like timing, which we're kind of talking more like gestational age, types of services, funding for services, and really, within that funding, access. So we started to see some real changes in New Mexico back in 2021. So introduced into the state legislature is Senate Bill 8. Texas ended up passing the controversial Heartbeat Protection Act. This was signed into law under Governor Abbott back on May 19th of 2021. It became effective on the 1st of that year. So this was a big change for us because regionally speaking, this already started to apply some pressure to patients who were needing services, and now basically had pretty much one of the most restrictive pieces of health policy that had been passed to date, which really influenced what we started to see in New Mexico. But the really big change we did see back on June 24th, 2022, when the Supreme Court finished their hearings and ruled on the Dobbs versus Jackson Women's Health Organization case. And this you may know better as either just Dobbs or the decision that overturned the Roe versus Wade precedent, which is still the case to this day. So I want to show you something. So I'm going to bring up some heat maps to go through some of the data that I analyzed when I was working with the Department of Health. So what this is showing in this heat map is we're looking at kind of southwestern, south central United States. These areas of density are actually are communicating where people were coming from to get services. Now, all of these patients were receiving services from somebody licensed in New Mexico. So some of them were operating remotely. So for those who were receiving mifepristone, possibly misoprostol, some of that was actually technically occurring from a provider outside the state, but who was licensed and able to provide services within the state of New Mexico. So for all intents and purposes, these services were being provided in New Mexico from a practical standpoint. The green you see on the maps are areas of low density, yellow a more intermediate density, and red high. So again, where you see the higher areas of those red areas are the areas where more people were coming from, or more pregnant individuals were coming from. Now I'm going to show you three different heat maps to show you the differences across time. This first one was showing where we were at just before the Heartbeat Protection Act was passed in Texas. The second one will be showing you after that legislation passed in Texas, but before the Dobbs decision. And then the last one will be everything post-Dobbs. Now, I'm going to go through these slowly, and then I'm going to show you them again so you can see something. And I will call my bluff ahead of time. There is an arrow on one of these slides that is really drawing your attention, and really pay attention to that area, because it's going to really change dramatically. So again, this is before Texas passed that law, or that enacted that law. This is now after that law was enacted, but before the Dobbs decision. This is post-Dobbs. So one more time here. So before Texas, after Texas, after Dobbs. So you may be noticing some things that jump out right away. And I want you just to keep that in mind, because now I've got a question for you. So I want us to think back to the theoretical frameworks we talked about. The socio-ecological model, health belief model, and social cognitive theory, as I have listed down at the bottom. Now, how might the three theoretical frameworks we discussed help us understand the phenomenon of shifting demographics in the patients seeking pregnancy termination services in New Mexico? And since we do have Slido up too, I'm going to pull this up. The only information that's removed from this slide is just our three frameworks, but the question is still up there. So please feel free to engage however you see fit. Please type your responses into Slido. Or for those here in the room, by raise of hands, I'm also happy to also take your responses and feed that back through the microphone here. Oh, let's see, let me go back here. Okay. Actually, I'm seeing here, I see somebody posted, but I may actually have to go over. Let's see here. May have to go over to the website here to actually look at our responses. Give me for just a moment. Okay. Looks like we have some typing going on, but for the sake of time, do we have anybody who would like to also offer any thoughts either over Zoom or here in Santa Fe about this question?
So I think with the health police model, post-Texas law and especially post-Dobbs, there's more of a perceived risk, and so that would have driven people to seek out more services. You see that huge increase in Texas.
That's a very good point too. So just to repeat that, make sure everyone on Zoom heard that. So the comment was about the health belief model and the risk to patients' health for everything that was going on. And that's a really, I think, a really good observation. Similarly, we kind of talked about within social cognitive theory that a lot of what we can see influencing people's behavior can also be driven by the environment, right? So this suddenly changed environment where it was already restricted, it got even more restricted, and now there's virtually no access at all, is a huge change and can really influence behavior. So any other thoughts on that? And maybe to prompt a little bit more, since we've kind of talked about health belief model and social cognitive theory, how can we relate the social ecological model to what's going on with an individual's health? A pregnant individual living in Texas. So maybe some thoughts to consider around that is we talked about the macrosystemic factors, right? So we're talking about a lot of the policy that is changing the whole system, all the way down to an individual's life through the process of restricting access, right? So under normal circumstances, people probably wouldn't consider driving hundreds of miles to get these services, but that's what's been happening. And a lot of time lost from work, a lot of people having to spend a lot of money both to travel and then also for childcare. So this is radically shaping everything across the whole board, starting with a policy change that comes down from there. And for everyone who posted on Slido too, I'm going to circle back around at the end here to see if we can't see your answers as well, since we're having a little bit of an issue getting that to display. So really quickly, before we get in with the other cases, I did want to talk about some of the other models that we're also probably pretty familiar with, but to also relate that back. And I want you to kind of have it in the back of your mind, things like social determinants of health and their very, very large impact on individuals' health, how that relates back to what we've been talking about around the social ecological theory, health belief model, and social cognitive theory. Because a lot of the way that we really identify these determinants has been actually springing forth from a lot of the theory here. And so because of that, we do see that we do see a lot of those common factors about somebody's environment, but also, again, the role of healthcare, which admittedly, when we factor it into everything, sometimes can play a pretty small part comparatively. So to also, bring up some other points too, there are the health policy issues in New Mexico. And some of these, a lot of these policy issues are not really so much for you to commit to memory. For a lot of our current third-year residents in Santa Fe, they've actually had a chance to really work with legislators and get very familiar with a lot of these. But I did want to bring these up because as we talk about a lot of these policy issues, these all come back to these huge macrosystemic factors that are affecting a lot of people. As someone who's about to get started with El Centro in September, I can tell you that one of the sites I'll be working at has very, very limited access to broadband, which from a healthcare perspective, I have actually never faced before. But it is affecting patients and providers alike and others who work in the community. And so these are things that affect people, very broadly. So I just wanted to frame that because I want to talk about two cases. So really quickly here. Just want to make sure, see if we can get our Slido to reset here. Okay, so I'm gonna read these out for you all, but then we're gonna get in with some questions where I would love to get your thoughts on this. Also, because of the tricky part of trying to project everything from Slido there, also feel free to throw any thoughts that you have into the chat. I can read those off and we can review those together too. So just into the Zoom chat. So here's our case. So we have Kim. Kim's a 38-year-old, null gravid, so hasn't had any previous pregnancies. A cisgender heterosexual woman living in Santa Fe County who has been your primary care patient for about 2 years. Despite multiple visits during which you two have discussed it, Kim has yet to complete her cervical pap smear for cancer screening. The last one occurred when she was 27 years old, and based on the United States Preventative Services Task Force for their recommendations around this, she should have completed, if she were on track, she would have completed her next one at 30. She has not shown up for the past 2 well woman exams, and you have scheduled for her over the past 6 months. You were concerned for her because she has had multiple new sex partners in the past 12 months and over 10 lifetime partners with variable condom use, all of which would place her at higher risk for an HPV infection. So here's what I'd like to get your thoughts on. So let's start from the top. What more information would you like to know about Kim's situation to guide her healthcare?
Why doesn't she want to do that?
Excellent. Why doesn't she want to do a pap smear? I agree. I would like to know that too. What else?
Her experiences with pap smears were like in the past, because clearly she's still coming to visits, but she's
Absolutely, a very great point. Her previous experience with pap smears, there could have been something traumatic that happened to that last one. There could be something else that is really influencing that we don't know about yet. And what else? That's fair. Absolutely. Getting more information, because from a risk stratification perspective, that also can either help raise or lower our concern for her as a patient. And maybe, let's see here. I'm getting a couple through the chat. I see family history could lead to fear of getting these done. I agree. Absolutely. And maybe one more, maybe from here in the room. Absolutely. I agree with that too. I think also that understanding is really huge here. And we also have another. Right. Yeah. So it looks like, yeah, Amanda's point too around, does she understand what the testing is for and the importance of it? I agree with you. So these are all really important points, but the important part, and you notice here that I have non-adherence in quotation marks, because really I feel like this is patient blaming, and I feel like it's not helpful. I feel like it's easy to blame people, but not to really understand systems and to understand this whole complex series of factors that could influence people's behavior. So let's move on to the second one. How can you apply each of the frameworks to understand Kim's behavior and non-adherence to medical recommendations for disease prevention? So maybe to help with the discussion, why don't we start at the top with social ecological, the social ecological model. What does that do to really help us understand what you all actually just commented on? Access, absolutely. Big factors, right? So what is the funding like for community clinics? She's in Santa Fe County, true, but Santa Fe County is actually pretty big, and Santa Fe County is not just Santa Fe. And so we already have issues with access here in this city, but if you expand that out to the county lines, you start to run into much, much bigger issues. I'll also throw another one out, interpersonal level. What if she has members of her family or friends who also don't get screened for whatever reason? There's kind of these norms that are being set in her environment that might influence her behavior as well. Anything else on the social ecological model that we could apply here? Absolutely. This is a huge issue for our patients. And then you factor into that things like transportation, childcare, all of that. This becomes a really complicated process, especially if there are other thoughts going into this that maybe I'm not as susceptible, maybe I'm not as, maybe this isn't as severe, which I'm also teeing you up for the health belief model. So, right. So if there's not that motivating factor there, what else in the health belief model could also help to explain the fact that she hasn't been screened since she was 27?
Maybe not being exposed to a case, not knowing anyone that has had any cervical cancer. Right.
So this is a perfect point. So yeah, not having seen anybody who's gone through this, and this is related to susceptibility. There's something that has been argued for in the psychology literature called availability heuristics. All you see is all there is. And so if you don't know that there's something out there that exists, or if it seems so distantly related to you, you may not consider it to be a threat to you. So so those are all things that definitely apply here. Now let's wrap it up. Social cognitive theory. How can we use this to really help us understand Kim's choices here? So we've talked about some of these already. There looks like we're getting something through the chat here too. Fatalistic perspective, if something happens, it's God's will. This is actually a really important perspective. And I appreciate you sharing that, because that actually is true, that from a cultural perspective, there is there is a certain level of fatalism that does exist across cultures. And so that's a really important point there. You all have also commented on things, the knowledge about this, the values of getting this done, any preconceived or previous experiences that could be shaping this. And then we've already talked pretty well about the environmental dimension, which, I mean, again, if you take nothing else from this, if you just remember that component, because that really unites the three together, is these environmental factors that are at play here. So really quickly too, let's answer the question, what overlaps in public health services and medical care can you identify in this scenario? So where do we see there being an overlap between public health and medicine and what we're talking about here? Because likely Kim is not the only patient for whom we're seeing the same pattern.
Overlap, for example, like prevent you from the prevention is the health insurance. Because that is a preventative measure that is covered by insurance, but if you don't have.
Absolutely. We just had a huge turnover within our Medicaid enrollment because of everything kind of resetting, right? So by show of hands, how many of you all have had patients who've actually become uninsured because they didn't get their turquoise envelope, they didn't know they needed to re-enroll, whatever the case may be? How many of you? I have taken care of quite a few patients who are in that category. This is a big thing because that is an example of that overlap there too, that there are those common interests and potentially areas that we could work together on too. So I appreciate your thoughts there on Kim's case. So I want to take us, and again, we'll come back around to slide out there. I want to take you into one more case to really drive this point home. So I want you to imagine going to work, we're talking about, you are about to attend a committee meeting. So this is a community medicine intervention case. So during the most recent Quality Improvement Committee meeting at your hospital, it was identified that your health system is lagging well behind national benchmarks from the Joint Commission on colorectal cancer screening rates. You work in northern New Mexico, where the population has very different sociodemographic and cultural characteristics from the general population of the country. The committee decided at the last meeting that colorectal cancer screening rates would be the target of this year's system-wide quality improvement efforts. So let's start from the top with our frameworks. We don't have to go in any particular order, but how can you apply either one or more of these frameworks to understand the discrepancy in the rates of colorectal cancer screening in your health system versus the rest of the country?
In New Mexico, northern New Mexico, there's lack of access, which is what we've been talking about. People have to travel 4 hours sometimes to go get their colonoscopies, and that's going to decrease.
Absolutely. This access issue is huge. And even, I probably am preaching to the choir for anybody who works in Santa Fe in this room too, because even here, there's kind of this thought that, oh, well, if we have it, we might have it here. But I think for anybody who's worked within our system, it can be 3, 4, 5, 6 months before you can get a screening colonoscopy done. And so that is definitely, access is a big thing there. Do we have any other thoughts?
Like super proud of the concept of autonomy here. Like we're so rural and so many aspects. I'm proud of that. Like I'm from the South Valley, we're so proud of that. And so when you have a doctor tell you what to do, we do not like that. And like you brought up the card thing, and the only reason I get buckled up is because my card screams at me when I don't. It's not because I'm thinking about the consequence.
Right. So you have a different cue to action, right? So and some of it's actually that negative, the negative input that you get if you don't do it, right? But so the comment was about autonomy and kind of the culture in New Mexico and the idea of healthcare professionals telling you what to do. And that is very true. I definitely agree with you there. And I think that some of the things that we can take from any of these theories that we apply is understanding that people are different across the board, and that the same approach doesn't work if you just do a blanket application of it to every single community. And so absolutely, I completely agree with you all there. So next question, how could you design a health promotion intervention in your community to increase screening rates? Because again, this is something that your health system has said, this is our priority. This is what we're doing. So what could you do to design something?
One thing one person can do is ask the question, why aren't people getting screened? And that way you can target an intervention towards that specific population.
I love it. I love it. So asking the question, why isn't it happening? So a needs assessment, right? So we have to actually start from the beginning of understanding our community and getting around that. So let's say we got that information. Let's say we have the needs assessment done. We've interviewed the community. We understand what's going on. What would be your next step after that?
Pay them to get the screen.
Pay them? Okay. So we're kind of suggesting kind of like almost like an incentive program, or kind of like a voucher
I think
program.
you could get a lot of people if you pay.
Yeah. Yeah. So making it easier to do the thing that we want them to do, right? But we're removing barriers. Maybe one more idea. What is something else we could do?
I feel like in my experience, thus far in medicine, which isn't much, but I think especially in America, we're very much like latched on to the idea that colonoscopy is the gold standard of screening. And rather than like putting on the patients to make a change, it could be a change within like physicians about advocating more for other forms of screening. Invasive and time consuming.
Agreed. And just to make sure everyone heard that on Zoom, so the point was made that colorectal, and this was actually intentionally worded this way for this reason. So colorectal cancer screening is not just colonoscopy. There are a lot of other ones. And we've definitely, like, on the over at the Family Medicine Center, have really had some conversations around like strategies for that. There are non-invasive options. Not everyone's a candidate for that, but that's the thing, is you can raise awareness through that. And a lot of people, when they realize that there are other options, are finally, they kind of feel like they have more autonomy in their decision making. I can choose which one is the right option for me, barring a few of the specific contraindications that we know about. So let's finally answer the last one to wrap up this case. So what specific divisions in the Department of Health or services might you leverage to maximize the success of your project and prevent redundancies? So I know we kind of went through it quickly, but just kind of like, just if you were to spitball an idea of just like, where would you start, or how might you reach out to somebody to get something like this going? Oh, I see something in the chat. Let's hear. Yes, I think that's a very good point with the promotores. I think that is absolutely essential, getting the community engaged. So we talked about this is your local health system, right? So you were working probably within one city. Maybe we think about this as the county. We talked about that there are a lot of offices that are set up at the county level that actually might be able to help you and may have funding available directly to do stuff like this. Other things, within our public health division or within some of the other divisions may actually also have access to resources where you don't necessarily have to recreate the wheel, or may even have promotional materials or people who are able to do this kind of work for you too. So again, just specific things that you can consider for later on. All right. So again, we'll go past that for now. So we went through those cases, and I wanted to leave you all with just a few key takeaways just before we wrap up. And then we'll do a little Q&A right before we ended 1:30. So public health is an inherently multidisciplinary discipline aimed at population health. And we talked about those 10 essential services. If nothing else, you don't have to know exactly what falls within the purview of public health, but just knowing, about what it roughly looks like and how to also enter into conversations with people who work in this area, because there are a lot of friends in high places who can do a lot of work for you, where you as the individual clinician, or you as somebody who's part, just an individual within the community, doesn't have to bear all this weight of making these changes. It really does take a village to make a lot of these changes that we've talked about today. Primary care clinicians should be aware of the structure and organization of the Department of Health and its services within their communities. At least just knowing that, these divisions exist and how this is all set up can empower you to really make the most of this and to know how to move through all of this. for our residents who are starting with the Medicos del Centro program, there's going to be a little bit more direct interaction with public health and with the Department of Health within our clinical space. And that's going to lead to a little bit more of a direct opportunity. But even for those who don't work directly with the Department of Health or employees of the department, there are ways to get involved and to get connected. Primary care clinicians in New Mexico can be excellent stewards of public health resources by keeping in mind these several key frameworks for understanding health behaviors. If nothing else, if you take nothing else from what I said, just remember that environment is a huge determinant. I know a lot of us have trained under that model and understand that, but if you can also keep in mind just these three major theoretical frameworks, I think it could be very helpful in even revolutionizing the work you do in your clinics. Some of our largest challenges in primary care here in New Mexico cannot be solved by healthcare professionals alone, and that's true everywhere. And there are so many people in our community who can be leveraged to really help us make those changes and to do all the good work that we want to do in the state. So with that, I wanted to leave a few resources. The slide deck too, I'm also happy to make readily available for anybody who is interested. A couple of the links I do want to point out besides the Department of Health website, which is definitely worth you checking out today. Healthy People 2030. Understanding our federal initiatives and our priorities around achieving better health in the United States. It can be a great place to start. Some of these are just some of my favorite books, and some of you probably already know that. But there's also a health policy series through the CDC that I think can be really helpful for those interested in that area. So with that, I'm going to open up the rest of the time for Q&A. We have about 5 minutes, so that way we can cover everything. But let me see too if I can also see those questions through Slido, since I mentioned that in the beginning. Yeah, it seems like we're maybe having some issues here. As a backup, I think I'm going to go. I'm going to have to go back on what I mentioned, but what we can do is any questions you can put them in the chat, and since we are having this issue, I'll take any questions from here in the room too by raise of hands. Got something in the chat? Oh yeah, yes, please do. Yeah, all feedback is very, very much appreciated. So yes, absolutely take that survey. All right.
One of the big issues with New Mexico, it's a different world from where I came from. Horribly underdeveloped in the healthcare delivery system, extremely poor, highest alcohol-related morbidity, mortality in the country, just really horrible access to care, partly because it's rural. Part of it is getting people in for whatever reasons. We have to start thinking outside the box. The problem with insurance companies and healthcare systems, they don't think outside the box. We have one GI group in town.
Right.
They could double the number of gastroenterologists and still be completely booked for months.
Right.
So they have to start thinking about, even though I'm not a fan of fit testing because its predictive value is nowhere near that of a colonoscopy. Do we get one? Do we start doing sigmoids in the office? Larry and I have talked about it. I used to do them all the time. They're very easy. We just need a bigger procedure room. For pap smears, do we adopt what they did in second and third world with self-sampling swabs for HPV?
Right.
It works. It's been proven. Insurance companies will not pay for this. But if we can get them at a reasonable price, they work.
It's a very good point.
I mean, does public health in the state need to take funding and use them outside the box from what's traditionally considered acceptable to get screening? And because it's just not going to happen. It's especially someone who lives 2 hours away.
Right. Definitely. And just to summarize for everyone,
or mobile clinics, bus like they did.
Yes.
Like they did in Cleveland, Tennessee.
Right.
They have buses around that go, or RVs that are equipped for healthcare. I don't know where they do them. Do they do them?
Santa Rosa, New Mexico.
Okay.
Yes.
Mobile. I'm just talking about actually real mobile health clinics that go rotate through rural towns.
Definitely. And just to summarize that for everyone on Zoom. So Dr. Black said, offered some really excellent comments, and really just, making the point that we do live in a state where, being creative and getting into solutions that are that bring the care to patients and expand access in ways that we just can't rely on, like a lot of areas that, major metropolitan areas where you may have like a GI doctor that works right down the hall and like, oh, I can get that person, scoped in a week or something like that. We are seeing increasing issues across the board in many different parts of the United States, but I think those are all really well taken comments and really important ones. Yeah.
It's interesting because the delivery hasn't broken out of the commercial model, the for-profit model, no matter what, whether it's a not-for-profit or for-profit, they all operate the same way.
Right.
And, really, if you're delivering healthcare to the population, there shouldn't be a profit-motivated delivery system.
I'm with you on that too. That's
for Bernie 5 more times.
Me too. And with that, I think we may have time for either one more comment or one more question if anybody has something.
Like that, I had worked so like patients do listen to the providers when they recommend like colonoscopy screening, and like whenever like promotora or we talk, and it's just they'll take the fit test but will not bring it back. So one of the big challenge with northern New Mexico is the providers shortage of time. For providers, and they are overbooked. So there is no, they don't come to the preventive medicine or like that. So like, we residents we have a little bit more time educating the patients that, colonoscopy. We picked up like at least 3 patients while I was there, colon cancer from the colonoscopy. So this education and then providers, lack of providers time.
Definitely. And I think just to mention that again, that everyone is so is so limited in their ability to be able to offer more services. And I think that limited time and everything that we heard, that those are definitely important pieces in all of this. And I think something that as we are going through together, working together, training together in this part of the state, that we think about this too, because just as a comment for everyone on Zoom and everyone in this room too, like it could be your work that really makes a huge difference for our patients too. And that breaking the mold is hard, but you don't have to do it alone, and you do have people who are willing to support you all the way through that. So with that, and to respect everyone's time, I really appreciate all your attention today and letting me have this chance to talk to you all about this. This is definitely a topic that's near and dear to my heart. As was put in the chat too, please fill out that survey. I'd love to hear what you thought about the session, ideas for future sessions, just anything that could be helpful. But with that, we'll go ahead and wrap up, and thank you all again so much for your time.
Thank you very much, Dr. Duncan, for that outstanding presentation. And with that, we'll go ahead and close it out. Everyone have a safe and happy 4th of July.